Hi, everyone. We'll just give a moment to let everyone make their way in. How are you, Dr. McGee? Back for round two?
I know. I'm so excited. I get to be here twice this week. So this is awesome.
That is so, we are the lucky ones. I wonder how many people on here were tuned in last night and tonight. A full week for you. So
Yeah.
I will get started. I know as people make their way in, they'll still make their way in, but we'll get started. And I know you have a lot of great information to cover. So, welcome to tonight's Wu University event, Defects, Dropout, and Dry Eye, Dealing with Dry Eye and Glaucoma. I'm your host, Dr. Jennifer Stewart, and thank you to Taya Pharma for exhibiting at tonight's event. Just a reminder, for each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. We'll display a QR code at the end of the event if you have that app on your phone. CE certificates will be emailed within 4 weeks. And make sure to ask questions using the Zoom on-screen floating panels. You can ask questions throughout the presentation, and we'll leave some time at the end to get through as many as we can. If you're on a mobile device, you can find Q&A at the top and chat under more. So once again, I think this is my 10th time. I don't even know at this moment, but I get the great pleasure of once again introducing Woo You favorite, Dr. Selena McGee. She's the visionary founder and owner of Bespoke Vision, a private practice that offers patients a wide range of optometric care via its dry eye center, specialty contact lens clinic, and aesthetics suite. She's a renowned national and international speaker, an adjunct assistant professor at the Northeastern State University College of Optometry, and she's on faculty at the Oklahoma Medical Research Foundation. She currently serves as president for the Intrepid Eye Society and the secretary of the Board of Examiners in Oklahoma. She's a fellow of the American Academy of Optometry and a diplomate of the American Board of Optometry. She's past president of the Oklahoma Association of Optometric Physicians and past trustee of the SECO board. She's the co-medical editor of Modern Optometry and associate editor of Presbyopia and the Aging Eye. She earned her Bachelor of Science degree in biology, where she graduated summa cum laude, and Doctor of Optometry, also summa cum laude, from Northeastern State University, Oklahoma College of Optometry. Once again, welcome, Dr. McGee.
Thanks, Jen. Good to see you. Hi, everybody. Welcome. And always a pleasure to be here with you guys. I am excited to talk about ocular surface disease in glaucoma. And there's my financial disclosures. All of these financial disclosures have been mitigated. And I had the distinct pleasure of putting together this Intrepid Eye Society consensus discussion that we published last December. And so it's hard to believe it's almost been a year, but it really made me dig a little bit deeper into, why we do the things that we do and how can we do things differently. And I was kind of astounded to find out that there's a lot of things that we do today that we could do differently to really help our patients who are managing glaucoma and then wind up with ocular surface disease. And so there's a lot here to kind of uncover and unpack. So I'm excited to deliver this kind of in a different way. And, we all have those glaucoma patients that we manage. And how do we also manage their ocular surface? And there's some nice studies in here, but throughout this discussion, whenever we published this, again, I learned a lot, and then we put together like a nice little like flow chart of when should we be thinking about the ocular surface? How should we be thinking differently and what that looks like? And so this is kind of a deeper dive into that. And I'm very privileged to be able to work with so many amazing companies in our industry. Eye care is really unique in the fact that the way that we all integrate and work together to better our profession is pretty special. And, people that work in eye care and they leave and go to another part of the medical profession or a different part of pharma, they quickly tend to come back because it is so special. So again, I'm very privileged to get to work with a lot of different companies. And so the way that we're going to demonstrate and talk about this tonight is looking at how satisfied are our patients with their glaucoma therapy? How do they adhere what should we be thinking about as we move through our algorithms, and how do we manage these patients when they have multiple things happening and going on? And so, this was an article that was published almost 10 years ago, but patient satisfaction with glaucoma therapy, reality or myth? And just because we're satisfied, because ultimately, we're trying to slow glaucoma down so that the patient retains functional vision for the rest of their life. And when we look at this, we're tend to be very focused on the one thing that we can manage, which is intraocular pressure. And maybe we're satisfied, but many times the patient isn't, because of side effects and things that happen with treatment. And so we're going to take a little deeper dive into this. The incidence of ocular surface disease in our glaucoma patients, it's high. So it's almost 60%. And it's multifactorial. It increases with age. So both of the risk factors for dry eye disease as well as glaucoma do increase with age. And as you start to add more medications, you wind up with polypharmacy, the frequency of the installation, how long they're on the medications, surgical changes that change the anatomy and physiology of what's happening on the front surface. All of those things are considerations, and those are all risk factors of what happens in our patient base that has glaucoma and many times has ocular surface disease. And if you talk to anybody that is a glaucoma specialist, OD or MD, they will tell you they have a dry eye practice, and it's because they've unintended consequences of managing glaucoma is often ocular surface disease. But we have some new choices, and we'll talk through that. This is a patient of Justin Schweitzer's. So I got to work, I work really closely with him. He and I are good friends. And we put together this talk last year for Academy. And this is one of his patients. And he treats a lot of glaucoma patients, works very closely in Vance Thompson's practice. And this is a long-time glaucoma patient, but he is saying, my eyes are red on a daily basis. My vision fluctuates. I miss my drops off and on, but my eyes feel a lot better when I do. How adherent is this patient going to be to their therapy when their eyes feel bad and they look bad, right? And so that's how we have to redefine what control glaucoma means. Yes, historically, we've been taught that it's measuring IOP and monitoring that, it's visual field changes and maintaining functional vision, and then looking at optic nerve and ganglion cell complex and making sure that we have structure. But, this patient's not controlled because he's unhappy. And so we have to think about the patient's quality of life. It cannot just be about the intraocular pressure at that moment in time. And so this definitely made me think differently long-term about how I manage my patients. And so this patient's not controlled because he doesn't feel good. He doesn't see well. So this is why we need to care about the ocular surface. And we're going to walk through some studies to really drive that message home. And we'll talk about how to manage that. So dry eye and glaucoma medication compliance. Dry eye disease is a very common reason why patients will stop their therapy, because their eyes feel bad. And, when you look at studies, there was a study that was done that looked, not this one, but there was a study that was done where patients knew they were being measured on how compliant they were. They're paid to be in the study. And even with all of that information, they still had a hard time adhering. And when you look at patients without dry eye disease symptoms, 89% compliance rate with their glaucoma medications. Converse with patients with dry eye disease symptoms, look at that, 63%. It goes way down. And so it really behooves us to ask how our patients are feeling. We have to manage the ocular surface if we're going to manage glaucoma well. This one study right here should outline that for us. So this is the leading cause of ophthalmic consultation is ocular surface disease. If you look at the number one reason why patients come into our office as a triage patient, it's dry eye disease. And when we look at this prevalence in our medically treated glaucoma patients, it's as high as 60% compared with the general elderly population. So same demographic, it's only 15%. That is massively different. And we have to focus and manage the front surface because it affects their quality of life. I mean, you look at the vision-related burden of dry eye, you look at assessing quality of life in glaucoma patients, looking at how they manage their day-to-day. And this is where that uncontrolled patient comes in and how we have to think a little bit differently. So when we look at compliance, patients are going to come in and they're going to have symptoms like my eyes are dry, they burn, I have gritty foreign body sensation, light sensitivity, objective symptoms, their eyes are watery, injection, their eyes are red, they look different. And then of course that's going to have decreased vision, which is the very thing that we're trying to prevent by managing and treating glaucoma. And yet this patient have fluctuating vision and decreased vision because their ocular surface health is poor. And so if patients have symptoms upon installation or any of the above, this is going to lead to non-compliance. And when you look at visual fields, which is one of the ways that we manage and know that glaucoma patients are doing well with their therapy, looking at reliability. And so managing that ocular surface, again, helps us manage the patient better because we have better visual field results when we're looking at their long-term data and managing their functional part of their disease. So physical findings, we're gonna go through these. We went through this pretty heavily last night. And so if you missed that, I'm going to walk through it again, but we have to look at eyelids and look at ocular skin and what's happening there. Demodex blepharitis is going to be a reason why patients don't adhere to their glaucoma medications because their eyes feel bad. So we're looking for lids and lashes, and then we're looking at meibomian glands and morphology changes. So structure changes as well as what we are functionally changing. Do they express? Do they have toothpaste? What's happening with meibomian glands? Conjunctival hyperemia, lid hyperemia, chemosis, and then we're getting finally to the cornea and looking at punctate staining. Does this patient have limbal stem cell deficiency? Do they have neurotrophic keratitis? And then tear film instability. So, if we walk through that with every single patient, starting with the outside and the ocular skin, then the eyelids and the lashes, then the meibomian glands, and then finally the front surface, that's going to help us address this with patients so that we're ensure that we're not missing anything. So when you look at cellular findings, what's happening when you have a patient on a long-term medication, say with a preservative in it, you can have goblet cell destruction. That's the mucin part of our tear film that everything sticks to, squamous metaplasia of the conj, corneal epithelial disruption, increased expression of inflammatory cytokines. We trigger that whole inflammatory cascade and we get into that vicious circle and cycle of dry eye disease. When we look at preservatives, one of the most common preservatives that are used in ocular medications is BAK. We know this has a direct cytotoxic effect on the cells of the ocular surface. And I'm curious, in an elderly population who may be already compromised, is this even a bigger problem? Conjunctival inflammation related to BAK can lead to filtering surgery failures. You get increased scarring. Surgeons have a harder time when a patient's been on a long-term medication that contains BAK. So a very simple way to manage patients is if they're using artificial tears or lubricating drops to help supplement the front surface, just make sure they're preservative-free. So that's an easy one right off the bat, low-hanging fruit. When we look at toxicity, we can see that with BAK, it can happen as low as 0.005%. Often in the concentrations that we use, it's 0.04 to 0.02%. And then in some over-the-counter products like cleansers, it can be 1,000 times more concentrated, especially in like those makeup remover wipes that are in like a little bag that patients love because they're easy and they do take off makeup really well. But BAK is hiding in a lot of things, and it's in plain sight in some of the medications that we've used. It's been around since 1940. And so we've been using this for a long, long time. What can we do differently? I think we should demand better products and thinking about how do we work around and choose differently when something contains BAK, because we know it's neurotoxic. Exposure just in 7 days causes decrease in aqueous production and causes decrease in nerve fiber density when you're looking at confocal biomicroscopy. And it's not just the preservatives. So that's one piece of this puzzle. But active ingredients can actually be part of this message too. So prostaglandin analogs, we know cause conjunctival hyperemia, delayed corneal wound healing, obstructive meibomian gland dysfunction. That's why we have to be so careful and walk patients through this. And, the first line of defense is typically going to be a prostaglandin analog. And so we got to manage that with the patient. And then patients are, unknowingly putting things on their lids and lashes to help with lash growth. And they often contain synthetic prostaglandin analogs because they're synthetic. They don't have to go through the normal FDA process. And I had a patient today who I am managing with dry eye disease, rosacea. She has Demodex blepharitis, the whole gamut. And she said, hey, I've been using this product off and on for several years. Can I continue to use it? And she showed it to me and I was like, well, let me see the name of it. And I recognized it and I said, okay, let's look at the ingredients just to make sure that it has what I think it has in it. And the active ingredients, of course, did not have the synthetic prostaglandin in it. So we had to check a new box and then go down about 30 ingredients in. And then sure enough, there it was, isopropyl cloprostenate. So this is a perfect example of making sure we ask good questions, because I've been managing her for almost 6 months. And somehow in all of our IPL, Lotilaner 0.25%, all the things that we're doing for her rosacea and her Demodex, we missed this one conversation. And she said, okay, great, I won't use this anymore. Is there something else I can use? And so we talked about just using a polypeptide, lipopeptide, to help her lashes stay healthy. So it's not just the preservatives, it's the active ingredient. Alpha-2 agonists can cause follicular conjunctivitis. We've all had that patient with a higher level of alpha-2 agonists that develop, contact dermatitis. And now you've removed a whole drug class from this glaucoma patient. And that is important when you're managing these patients. And so you really have to demand the pharmacies listen to what you're prescribing and not just switch stuff willy-nilly at the pharmacy because they want to switch to something generic that's good for the pharmacy, not good for the patient. So when we look at effects on meibomian glands and lids, this was a study that very closely looked at symptoms, also tear breakup time, corneal staining, their meibography score, and their meibum score. And we see that patients on different medications, they'll have reduced number of meibomian glands, reduced number of acini, and increased dysfunction in patients. And when they're on multiple medications with preservatives, then we see that number even go higher. So that's where that polypharmacy comes into effect too. And so when we look at, there's multiple studies out here. Here's another one looking at effects on meibomian glands. And that's why it's so important for us to really look at this and look at functionality as well as structure, just like you would in your glaucoma patient. You're measuring visual fields, that's functionality. You're measuring vision, functionality. You're looking, and no one in this day and age would manage a glaucoma patient without an OCT and looking at ganglion cell complex and what's happening with the retinal fiber layer. And I wouldn't expect anyone to not look at meibomian glands either, right? Once we know better, then we need to look and make sure that we're managing the meibomian glands effectively, as well as what's happening at the optic nerve. So all this to say, glaucoma therapy, here's another study, exacerbated ocular surface disease. So 101 patients, ocular hypertension, completed OSDI, 59% had symptoms, and it increases with the number of drops that they're on. So one drop about half of patients with symptoms, 2 drops, 62%, 3 drops, 68%. Not to mention that compliance goes way down when you start adding multiple drops. But that impact of glaucoma medications on dry eye disease, look at the incidence and how much that changes. One bottle, 11%, but in 19,665 glaucoma patients, 51%. 2 bottles, 55, 3 bottles, 60%. That is massive. And we have to be really intentional about asking good questions and looking for dry eye disease and proving to ourselves that these patients that we're managing with glaucoma, we're also proving to ourselves that we are managing their ocular surface disease. And there's multiple ways to do that. But when we think about how we're going to manage patients, there's a lot of ways to go about this. Preservative-free is very easy and accessible. We've got, delivery systems that are different, that are effectively, leaching onto the front surface. There's, scleral lenses where the medication is actually imprinted onto the front surface of the lens. You've got topical ocular inserts. We've got intraocular inserts. Maybe the patient needs a drop holiday and you can do an intraocular insert. So there's a lot of ways that we can manage patients and get to the end result if we think very intentionally about this. Because we know based on all the algorithms that are out there, whether you're looking at TFOS, DUES 1, DUES 2, soon to be DUES 3, Ascaris, CEDARS, we know that we're losing homeostasis in those glaucoma patients. There's tons of data in the literature. This is one of my favorite slides that really connects all the dots, at least for me, because the very definition of dry eye disease, I think, was said best by Donald Korb years ago. It's when the ocular surface structures fail to protect itself from desiccating stress. Well, what the heck is desiccating stress? Well, any topical drop that has a preservative is going to have desiccating stress. It's going to stress the front ocular surface system. And if the patient is at risk, or if they're on this chronic and long term, we're going to wind up with tear film instability. You have tear film instability that morphs into, now we have hyperosmolarity. The salt content goes up because the tears are evaporating too quickly. Now you have cell damage and you get apoptosis. We're going to see that at the slit lamp with epithelial changes and corneal staining. Now the body's going to say, oh, we got a problem. And all these cytokines are released. And now you have inflammation. Now you're losing goblet cells and you have more tear film instability. And the cycle just continues, not to mention what's happening on the eyelids. As you have tear film instability, you get flora changes. So patients are going to have more bacteria. They're going to have more parasitic infestations like Demodex blepharitis. Then you're going to have esterase and lipase release, which is going to cause eyelid inflammation, telangiectatic vessels, more leaky vessels, and the lipids actually going to change. The melting point of the meibum is going to go up. Now you've got toothpaste, not olive oil. So that's how we get into this vicious cycle. And multiple ways that we get there with glaucoma patients: topical drugs, again, preservatives. Maybe they have a bleb surgery. Maybe they have some kind of implant. There's multiple ways. And some of my worst patients with neurotrophic keratitis and dry eye disease were actually glaucoma patients that we triggered that during one of their surgeries. So the key here is, when you're managing your glaucoma patients, obviously you're going to monitor and always measure IOP and your OCT and your visual fields, but be really proactive in looking for symptoms. Don't wait on the patient to say, man, these drops, my eyes feel bad, doc. Do I have to take these? Don't wait on that patient to volunteer that information. We use a speed questionnaire on everyone. Comprehensive exams, glaucoma follow-ups, dry eye follow-ups, dry eye consults. We use that speed questionnaire so that we're proactive about what's happening with the patient and how they feel. And there's multiple different questionnaires. We just happen to do a speed questionnaire. Looking at tear composition. So I talked about osmolarity. That's going up when you have tear film instability. because the salt content goes up. Why would the salt content go up? Because the tears are evaporating too quickly. It's a supply and demand issue. They're evaporating faster than the patient can make them. And so this is, for me, osmolarity is what IOP is to glaucoma. Osmolarity is to the front surface and the ocular surface and dry eye disease. It's a measure in time so that I know what's happening with that patient, because I can't see osmolarity, just like I can't see IOP. I can see the damage that both cause down the road. When you have too high IOP, I can see visual field changes. I can see changes at the optic nerve, just like I can see epithelial changes to the cornea and the conj when we've had osmolarity that's too high, but I can't physically see IOP and I can't physically see osmolarity. So those two things for me are instrumental in how I manage patients. And then MMP9 is a non-specific inflammatory marker that certainly can be present. I like these two tests together because when I measure them together, actually the absence of one or the normalcy of one tells me a lot. So if I have a patient, for example, that has a normal osmolarity, but their MMP9 is really high, they have a lot of inflammation, that tells me that it's not dry eye disease. Either I've got neurotrophic keratitis, I've got conjunctivochalasis, I've got EBMD, I've got allergic conjunctivitis. I have something else on board that is not dry eye disease. So sometimes the normalcy of a test will actually point you in a different direction. And if you just do MMP9 and not osmolarity, you're not going to know. So I like these two tests together. What's normal with osmolarity? Anything around 300. And we want them to be pretty close between each eye. So think of the glaucoma patient. How many points do you want your IOP to be within? Typically 3. Anything above that, we're scratching our head going, okay, what's happening here? Why is this pressure so different between the right eye and the left eye? So osmolarity is exactly like that. We don't want big differences between the right eye and the left eye. So anything for osmolarity above 8 intra-eye differences, that is significant for me. And actually that inter-eye difference is a hallmark for dry eye disease. And the bigger that number difference actually makes me more concerned than the patient that has just a high osmolarity and they're pretty equal. So just some pearls there. When you look at, again, this cascade of inflammatory events, then we've already talked about cell apoptosis, and then you start to lose goblet cells. And again, you get into that vicious cycle. And remember that MMP9 plays an integral role in basement membrane degradation. So contains collagens, can be degraded by MMP9. So these normal levels range anywhere from 3 to 41 nanograms per milliliter. So you have to have enough inflammation for it to read. And remember, this is just one marker. There's tons of inflammatory markers that we just can't measure yet. So, diagnostic testing is very important, just like it is in your glaucoma patient. So remember that as you're moving through this. Tear quantity, we're looking at tear meniscus height. That's an easy way to know, is this patient normal? They have a high tear meniscus height. Are we looking for epiphora? Do we have conjunctivochalasis? Is it really low? Do we have aqueous deficiency? Should I be looking for Sjogren's? And then, of course, we're looking at vital dye to assess corneal health and what's happening with the conjunctival and corneal cells. Lid structure and function, again, we've already talked about this. Make sure you're measuring that. In those patients where you have aqueous deficiency suspicion, then we need to make sure the patient doesn't have Sjogren's underlying. So when we start with patients, we want to look outside and then work our way in. And this is a great example of someone that is on a glaucoma medication and also has Demodex blepharitis. Remember, patients are allowed to have more than one disease process. But if they feel bad, their eyes are itchy, they wake up with mattering in the morning, and they take their glaucoma drop last thing at night, what's their conclusion? It's probably going to be, wow, is this drop like causing a problem? And so having that patient look down and making sure that you inspect very closely what's happening at the base of the hair follicle so that you can address this with lotilaner 0.25% and your lid scrubs. So looking at, again, cornea, tear meniscus height, I like that Ratten filter when I'm looking at staining because it lights up like a Christmas tree. I can see things a lot easier. So what do we do? How do we manage these patients that have glaucoma and ocular surface disease? So we have a lot of ways to do this. One of the most straightforward ways is choose preservative-free formulations. When we have both significant improvement in signs and symptoms, when patients were switched to preservative-free medications, and we have that option, we have data that shows that preservative-free latanoprost is equal in efficacy to latanoprost. So there's no reason for us not to choose a preservative-free option when we have it readily available in the United States. And we've had this readily available for, close to 18 months at this point, I believe. And so this is something to consider when you are choosing your first line med, and most of us are choosing a prostaglandin analog, then choose one that's preservative free. And we have that available. And now, again, we know it's just as efficacious. And we have, combination therapies that are also preservative free. There's even triple, quads that are preservative free. So choose preservative free first when you're reaching for that first line therapy. We can also do SLT. We can do, MIGS based procedures. We can think differently about how we want to manage this patient. And remember that SLT selectively targets and laser burns those pigmented trabecular meshwork cells so that we intentionally create that little bit of inflammation, so that opens that up so that our aqueous humor can flow through faster. This is based in really good data with the light trial. And this was looking, at patients' first line therapy versus medication therapy. And what we see in ocular hypertension and glaucoma is the quality of life at 3 years. That was the primary outcome. Secondary outcome was cost effectiveness, clinical effectiveness, and safety. And what we see is when patients, there's no significant difference in quality of life. So 97% probability of SLT is first line treatment. It's more cost effective. And we get to target pressure 93% of the visits, and then target meds. So 78.2% of those patients that were on SLT remained drop-free at 3 years. And when you look at 6 years, so this was extended, and the quality of life at 6 years, secondary outcome was clinical effectiveness. Again, no significant difference in quality of life. And we see that 26.8% versus 19.6% progressed on drops versus SLT. So patients progressed faster and more patients progressed. And then we had to have a TRAB in 32 of the eyes that were on drops versus 13 of the eyes in the SLT arm. 69.8% of those SLT patients were drop-free at 6 years. That is massive. And if you have younger patients and you want a way to manage their glaucoma without them being adherent to a medication long-term, SLT certainly has good data behind it. 70% of patients at 6 years. So it's repeatable, right? And when you repeat it annually, this is what the COAST trial showed us, that you've got newly diagnosed POAG treated with ALT 360, standard SLT is needed, or low energy SLT 360 repeated annually. And the 10-year results showed that low energy SLT, 6.2 years, median time to treatment. And so we can extend these patients between what they're utilizing medication free and then median times to treatment. And when you look at SLT, Belkin just brought an SLT laser to the United States. I think Alcon is who is going to commercially promote that. But now with SLT, with that Belkin laser, you can do 360 degrees with one pulse instead of using your gonio lens and turning it, 4 times with your rapid SLT lens and firing all the way through. So it's going to be even, I think, more accessible for people to utilize that when you've got a tool like that kind of laser. This is pre and post. This is one of Justin's patients, post SLT. I mean, look at that ocular surface. You can imagine how much better that patient sees, how much more comfortable they are. Just a world of difference pre and post SLTs in one of his patients. This is just a great, reminder video of SLT And you're looking at those little champagne bubbles as you move through the trabecular meshwork. And this is not a complicated procedure in the sense of how you're doing it. If you can do gonio, then you can certainly do, that's the hardest part, is getting into the right place. And then you can see all the little champagne bubbles there. That's exactly your clinical endpoint, as they just move through the trabecular meshwork. But if you want to explore this, and now we have 11 states that can do this, then you need to start practicing your gonio and making sure that you're doing that on as many patients as you can do it, because that's going to be your biggest challenge, is your gonioscopy skills. And we should be doing gonioscopy on every single glaucoma patient at least annually, and on every single patient when we diagnose them. There's no way to diagnose someone with primary open angle glaucoma unless you actually look at the angle. And so just remember those gonioscopy skills, dust off that lens, get that bad boy out, and start using that again. Another like little fun video, just again, showing those champagne bubbles as we move through, and selectively targeting that pigment that lives there. And again, you see your little champagne bubbles there. Oh, this one's got music to it. So all of these videos came from my good friend, Dean Nate Lighthizer at NSU, because he's got some wicked surgical equipment and some really cool video equipment that he can do these with. So thank you, Nate. Thank you, Justin, for helping put all this together. So we've got a lot of ways to manage glaucoma that is not what we would consider traditional. We've got ocular surface devices. I talked about that scleral lens that has medication actually imprinted, 3D printed onto the front of it. We've got microdose latanoprost. We've got things that we can put into the front part of the eye, whether it's an extended injectable system like bimatoprost, travoprost extended. There's punctal plug devices that elucidate medication onto the front surface, so it's not drop related. Lots of ways to do that. Bimatoprost is one of the ones that was first FDA approved and indicated to reduce IOP. And I think I have a good video of Justin like doing this. And yeah, we do. And so, even if you need a patient to just take a little drop holiday, which is what he calls it, and I think that's so aptly named and such a keen concept, maybe they just need a break for 6 months to a year. And you can, do one of these bimatoprost injections, and you put your little pellet right down into the anterior chamber and drop it right in there. You're going to see it fall. There it went. And that's going to elucidate bimatoprost over the next 6 months. And, patients often, there's studies now that show that they will have extended IOP control beyond what we would anticipate when we think it's going to last 6 months. And here's that data. So there's 24-month phase 1 and 2 clinical trials with that bimatoprost pellet looking at 24-month IOP reduction versus topical. And we see that at 24 months, in a large portion of those patients, it was still working. And even though we think it's gone in 6 months. So 68% needed no rescue or retreatment at 6 months, 40% at 12 months, and then 28% of those participants at 24 months. So pretty impactful data. So again, thinking about MIGS and reaching for something different and working closely with your glaucoma surgeons to co-manage these patients. And like my glaucoma surgeon, we're not in the same practice. He's in private practice. I'm in private practice, but he sends me patients often to help with ocular surface. I send him patients often to help me with MIGS procedures. There's lots of ways to like do this together. And again, this was what we had put together as Intrepid, and my cohort that I worked on this with was Dr. Jacob Lang, Nate Lighthizer, Jackie Garlick, and Mark Schaefer. And when we put together just how do we think about this? Can we give doctors a decision tree on when to choose preservative-free? And it's pretty straightforward. Am I treating the patient for a chronic disease? No. Okay. Is the patient going to use the drop on a daily basis? Yes. Okay. Is it acute? Is it perioperative? We've well established that we're going to use preservative-free medication and refractive surgery. We've been doing that for almost 2 decades at this point. And then cataract surgery, same thing. So why wouldn't we think about that with over-the-counter lifestyle products? It gives us something to think about. If the patient's using it on a daily basis, chronic, long term, just because it's a lifestyle medication doesn't negate the fact that it's going to have a preservative in it. So that's a good decision tree. And then, is the patient being treated for a chronic disease? Yes. Are they being treated daily? Yes. Do they have pre-existing risk factors? Okay, then maybe we choose something preservative free. No, maybe it's episodic. Does the patient already have ocular surface disease? No. Okay, then maybe we just watch him a little bit closer. Yes. Then maybe we watch him even closer still. So this gives you a good, just kind of, again, decision tree of when should I be reaching for something preservative free. We've already talked about lids. Make sure you don't miss anything here. So for our last 10 minutes, I just want to walk through how I would manage an ocular surface disease patient. And questions that I love to ask are, when do your eyes feel worse? Is it in the morning when you first get up? Is it as the day goes? If we're worse in the morning when the patient gets up, I'm looking for lid seal problems. I'm making sure they're on an ointment at night, working with goggles, something to help prevent that poor lid seal at night where they wind up with exposure keratitis. Inflammatory ways to manage patients. We have 3 different cyclosporins available to us. We have lifitegrast designed specifically in a lab to address inflammation in dry eye disease. Steroids, we've had a long-term effect with. We just have to be careful here because many of your glaucoma patients may be steroid responders. So just, not that you can't use them, just be very mindful. Omega fatty acids, of course, low-level light therapy, IPL, autologous serum, amniotic membranes, all of those things. We can use lubricating drops. Just make sure they're preservative-free. I like autologous serum, especially in a patient with neurotrophic keratitis. When it's not just dry eye disease, and this frequently happens in glaucoma patients, post-surgical and long-term disease on the front surface because they've chronically used a medication. And remember that little nerve plexus that we showed at the beginning when BAK affected that nerve plexus just in 7 days. And so is it dry eye disease or do they have neurotrophic keratitis? And the only way we're going to know that is to stain the patient and test corneal sensitivity. Patient has neurotrophic keratitis, then we need to manage that utilizing synedromine, which is the only commercially available drop that is known to treat neurotrophic keratitis. So I use this, and I've used it in many a glaucoma patient. We talked about cyclosporin. IPL is a great way to manage the patient who has inflammatory rosacea, telangiectatic vessels in a patient because you're not addressing something on an ocular surface. So it's ocular sparing. Neurostimulation is a key one because this is ocular sparing. When we think about how the endogenous tears are produced, and when we go through that system, we're looking at that lacrimal functional unit. It regulates tear secretion. So remember, those 7,000 nerve endings that live on the front surface are constantly monitoring the environment. Do I need to make more tears? How fast are your tears evaporating? It has this cooling effect with TRPV8 receptors. And those little receptors are sensitive to cold. So when your tears evaporate off the front surface, you get that cooling effect. The TRPV8 says, okay, I got to make more tears. It tells the brain that. The brain comes back around and says, okay, great. I'm going to stimulate the meibomian glands, stimulate the lacrimal glands and the accessory glands, and I'm going to stimulate the goblet cells, and we're going to make tears. But anything that interrupts that pathway, we're going to have a problem. And so if we can bypass and stimulate that lacrimal functional unit, then we can make the body make its own tears. And we have that capability when we're looking at things like varenicline, which is made by Oyster Point, and the nose spray. When we look at Olympic Ophthalmics has a product called iTear 100. It's an external stimulator. If those of you that remember TruTear back in the day, that was an intranasal stimulator. It's no longer available. But there are ways to stimulate that LFU so the body makes its own tears. I love this because it's ocular sparing. I'm not putting something else on the front surface of the eye. Chlorpyrrolhexyl we're utilizing this because it prevents evaporation. It mimics the natural meibum. So it lowers surface tension, helps prevent that evaporation. And these, when you look at the side effect profile and the tolerability of this drop, it's not like anything else we've ever done. And so this is something that has become very much part of my routine with glaucoma patients. We've already talked about steroids, low-level light therapy we can handle with inflammation, osmoprotective agents. So look for very key ingredients in your preservative-free lubricating drops. Trehalose has bioprotectant properties. And when you couple that with hyaluronic acid that's in an artificial tear, this helps prevent that hyperosmolar tear film from damaging the ocular surface. Remember, you've got hyperosmolar conditions. It's a high salt content because of evaporation rates, and the epithelial cells start to die. But if you have a product like trehalose that is osmoprotective and can help prevent that, then I'm absolutely reaching for that. And so you've got products available on the market that are preservative-free that do contain trehalose. So a couple of things to look for. Punctal plugs, again, you're preventing something from being on the ocular surface. When you look at this in glaucoma patients, they actually have a very good outcome when you're coupling that. Something that's new and different is lacrimal filler. So we're putting this in the canaliculus. It's a cross-linked hyaluronic acid that allows everything to stay on the front surface, allows your glaucoma medication to stay where it's supposed to be. And you can fill that canalicular system for each patient. It lasts up to 6 months. You use the same code that you would use for a punctal plug, but I've had great success with this. Again, one less thing the patient's having to do. I'm intervening on the patient's behalf, and they're not having to adhere to another medication. Scleral lenses, especially if you have someone that has a bleb, if you have someone that you need to work around something that a surgeon has done, then we have scleral lenses available with iPrint Pro. It's a mold of the front surface that we can work around those things. But that sterile bath on the front surface can certainly help us mitigate some of the things happening on the ocular surface. Supplements are a very straightforward step one in my protocol for patients. I'm looking for data around what is in the literature on which supplement I'm choosing. I like ones that have GLA so that I have the right cofactor so the patient actually absorbs that. We're working from inflammation on the inside out. Heat and expression. If we have meibomian gland dysfunction and we have blockages, we have to unblock those. So we have to unobstruct the gland. And there's lots of ways to do that. And again, those are ocular sparing, neurostimulation, IPL, heat and expression. I'm not putting something else on the front surface of an eye that is already compromised. This is one of my patients, referral from my glaucoma surgeon. He's like, I've got to help this patient. Here's his speed, 17 out of 28, osmolarity, woof, 337, 339, positive, 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 inflammatory. Current glaucoma medications, Combigan, Lumigan. He's had SLT, CyPass, and Omni in the right eye. His pressure is 10 and 15. He's tried Restasis, Doxy, Omegas, punctal plugs, Isubis. He's tried everything, and my glaucoma surgeon is like, please help me. So we wound up doing IPL. We did varenicline because, again, ocular sparing. And he wasn't on Restasis very long, so I kept him on that. So after his IPL, we went from 17 to 13. Look at his osmolarity, 305 and 308 from 337 and 339. Negative and negative on his inflammatory. So we planned to continue that ocular sparing protocol, IPL, varenicline, and his Restasis. So key takeaways, ocular surface disease is very common in our glaucoma patients. It affects quality of life, it affects their patient outcomes, and it affects their visual outcomes. And it might affect IOP if they don't adhere to the very medication you're trying to give them to prevent their functional vision loss. BAK can be deleterious to the ocular surface. We have alternative therapies that are safe, that are effective, and we need to be reaching and demanding for these more. So think about that patient when they're sitting in the chair, what you're doing today and how that's going to affect the patient long term, not just at that moment in time. I'm going to do what I need to get that IOP lower. I want you to think about that patient long term. And is this medication, or should I think about a different medication, preservative-free, or should I think about a procedure, not just about their IOP at that moment in time? And so that is what I wanted to share with you guys in the glaucoma world, in the glaucoma patient. How do we manage their ocular surface disease and create that awareness for you guys? So if you have questions, of course, there's my email. This is what's coming up for COPE approval, pediatric keratoconus planning and post-op care for cross-linking. So I have gotten the privilege to work with Brandon on multiple different fronts. Typically, it's ocular surface disease. He is a brilliant and skilled surgeon. You guys do not want to miss his talk. I learned so much from him. I learned something from him every time I talk to him. So save the date for November 14th. 5:30 Pacific time. That's an event you don't want to miss, and I promise you I will be in the audience for that one. So let me look and let's see what questions we have in the chat. So one of the questions is accessibility, and if we don't have accessibility to the very medication that we want for our patient, it's hard to pull across. But I do believe that unless we demand and we work the system from the patient advocacy standpoint, that we're never going to have preservative-free prostaglandins available to us if we don't actually prescribe them. And so accessibility is part of this conversation, but you can't let that deter you, and you cannot let that drive your decision-making, because it will never change. So I think that I never said it was easy. So I said you should choose this, but I never said it was easy to get. There are a lack of insurance coverage issues. That's why I'm giving this talk and this discussion, because we have to demand better for our patients, and we have to stand up for what's right and fight for better options long-term for our patients. So I'm super happy that you brought that up, because it is very important, and you're absolutely right. So I will send you guys the handouts. That way you've got accessibility to all of this. I do want to give a shout out to Dr. Schweitzer. He gave, that first case, and a lot of these studies he's very intimately familiar with that I learned along the way. Ben Gaddy was part of that as well. I learned a ton from him in the glaucoma space, in the glaucoma realm. So let me see if we have other questions in the chat. I want to make sure that you guys have plenty of time also to get over to your presentation from Taya. So
There's some in the Q&A.
Okay, let me look in the Q&A. Okay, so what about cost for switching to preservative-free? Is there an option that is cost affordable? So I think you're going to learn about that here shortly. Stay tuned. Considering the efficacy of SLT, why universally isn't this technique the first line of treatment? I 100% agree. And it seems like most clinicians still start on drop therapy. I think there's this intimidation factor, and I offer SLT first line therapy. I think it starts with us, because these patients are sitting in our chairs. We're the ones that are managing these patients. So I think it has a lot to do with prescribing habits, behaviors of physicians managing, and accessibility. When you only have 11 states that can do SLT with optometry, maybe that's part of this conversation. And so I agree with you. I don't know why it's not universally first line of treatment. I think we just need more time, and people need to be more accepting of it. How many patients have a problem paying for the more expensive preservative-free drops? So I think there's this big perception that they are more expensive, and I would encourage you to stay tuned, because I think some of those perceptions might be not accurate. a link for pre and post test. That's going to be you guys' handouts. What are your thoughts on MIBO? So let me answer that one real quick with our few minutes we have left. So MIBO is perfluorohexyloctane. It helps prevent evaporation, and it mimics MIBOM in the sense that it's lowering surface tension, preventing evaporation, which is what MIBOM should do. I love this drop in my ocular surface disease patients, and I also love it in my glaucoma disease patients because of the tolerability side of things. Patients tolerate it very well, and when you look at the clinical studies with Gobi and Sahara, you see that, and I see that clinically as well. When you are utilizing this, because of the way that it behaves on the front surface of the eye, it's an amphiphilic molecule, so it wants to just bob around in the tear film because of the way that it's built. It's got 14 hydrocarbons. You've got 6 fluorinated carbons that are highly aerophilic, that live up here in the air. You've got the 8 saturated hydrocarbons that are highly lipophilic, so they're oriented in the tear film. But the question I always get is, when should I use it? Do I use the glaucoma drop first? Do I use MIBO second? So you always want your, whatever drop you're using, you want MIBO to be last. And the reason for that is because it's teeny tiny. So it's 11 microliters. It doesn't have water. It's 100% perfluorohexyloctane. But based on the molecular makeup of that drop and based on the way that it behaves on the front surface, just always use it last in your algorithms. So one of the questions is, where does CEQA fit in your treatment regimen? So cyclosporin is always part of my treatment regimen with patients that have ocular surface disease. And CEQA is unique in the fact that it has these nanocellular micelles that surround cyclosporin. And remember, cyclosporin is a very hydrophobic molecule. It does not want to be anywhere near the tear film and the conjunctival and corneal tissues where we need it to be. So you have to look for ways to get it there. And CEQA did a great job with that nanomicellar technology. The other thing that's really interesting, if you want to look up a cool study that very much behaves like a glaucoma study, years ago, we learned that if you switch within a class in glaucoma, that sometimes you can get better efficacy. So maybe you have somebody on a prostaglandin. Before you abandon the class, switch them to a different prostaglandin, because often you will get a better result. They did the exact same thing with CEQA and Restasis. They had patients that had been on Restasis for a median, I believe, of 38 months. I'm pretty sure it's either 38 or 39, somewhere in there. 38 months, and they switched them from Restasis to CEQA. And they saw the same thing, that when you switched within that drug class, that you had a better result. And they were looking at Schirmer's and they were looking at symptoms. So that is another way that I think there's so many similarities in the way we manage glaucoma and the way we manage dry eye. So that one I think was very interesting.
Looks like we have time for one more.
One more. Okay, so I'm gonna do this last one. Are you concerned about affecting efficacy of glaucoma drops when I use Restasis, like drops or MIBO? I'm not. So I just wait 5 to 15 minutes between drops so that I'm not washing out what we just put in. And then, like we talked about, MIBO is the last thing that goes on. So yeah. Perfect. Great questions, you guys. Thanks for tuning in.
I know there are so many more questions coming in, and there's never enough time. We just need to
know. So sorry.
Just log on and just shoot questions at you. So, thank you, Dr. B. Once again, thank you for an amazing presentation that is just so useful for all of us in our practices. And I echo lots of the amazing comments that are coming through about how much we've learned and how much we appreciate you sharing your wisdom with the WU community. You are one of the most requested speakers, so it is always great to have you here. So
thank you. I really appreciate that.
Thank you.
All right. Great.